Hello, everyone. This is Dr. Susan Hudson with Texas Fertility Center with another episode of Fertility Docs Uncensored. I am here with my feisty and fabulous co-host, Dr. Carrie Bedient from Fertility Center of Las Vegas.
Hello.
And Dr. Abby Eblen from Nashville Fertility Center.
Hello.
How are you guys doing today?
Great.
Good. Hot, glad to be back inside.
Were you outside this morning?
Yeah, we went so they opened a mini golf course that's based off of like Tiger Woods' stuff.
Oh, wow.
Maybe a couple months ago now. And so I have a big golfing family. I don't know how to golf worth a hill of beans, but
Yeah,
but I have a golfing family, and so everyone was really excited that they could take their own putters, and you get like actual legit golf balls, not the dinky, stupid, multicolored ones that you get at a mini golf course where you're using plastic putters and all of that. And
Yeah.
so we went, and it's more expensive than regular mini golf, but they let you go in and out all day, and you can play the course as many times as you want.
Ah.
And it's like a nicely set up legit course. There's no windmills.
It's mini
here.
golf though, right? It's mini golf.
It's mini golf, like it's straight putting, but
Yeah.
there's no like windmills and haunted house and giant clown that you have to like hit the nose or like those types of things.
Mini golf for adults then.
It's mini golf for adults, yeah. Although
Are there beverages included?
Yes.
They're not beverages included, but it is well set up. Like you can do mobile ordering while you are out there on hole whatever, and they will bring you things. And there's a bar right smack in the middle of it. I mean, this is Vegas.
Okay.
And so plus they've got other games like ping pong and what have you, and a restaurant, and they've even got a playground for little people. And like it's a well thought out idea, at least so far. Only it's the middle of Las Vegas and it's freaking hot outside. And so
Yeah. Oh yeah.
I have a well thought out idea. It's been like, 4.5 years since the last time we met in Vegas. Maybe we need to meet and do a little putt-putt.
I think that's a fabulous. I will plan out the entire weekend. But guests do need to wear sequins.
Okay.
Doesn't have to be a lot of sequins, but really there should be some
little sparkles.
Yeah.
So you're telling us we have to dress like showgirls? You said not all the sequins?
Not all sequins are showgirls.
I mean, I'm not saying get 2 big sequins and that's all you're wearing on top.
Yeah.
Although if you want to, Abby, I will fully support your midlife crisis, and this is the right place.
That so fits my personality, Carrie. I'm so.
I know it does. We'll get you some artfully placed feathers as well, and you look so
I like
fabulous.
feathers. Those are cool. Yeah, I mean one here and a couple here.
Yeah. Yeah, no, I think that's a fabulous idea. So yes, we should get together in Las Vegas and have a girls' weekend with all the fun things.
We should. Let's answer a question, okay?
All right.
All right. Hello, docs. I'm 36. Fiance's 31. We started our fertility journey 2 years ago. All my diagnostic tests have been normal, except I'm a carrier for SMA. My fiance is not a carrier for any disorders. Semen analysis is also good. AMH in 22 was 0.4 and AFC was 3. We got pregnant twice unassisted and once on a medicated cycle. Had a chemical 11-week miscarriage and a blighted ovum. We did recurrent pregnancy loss panel, all normal. My most recent testing showed AMH of 0.093, FSH of 8, estradiol of 55, TSH 3.53. Everything I've heard about thyroid is it should be lower, but my clinic says they won't treat it because I'm within normal range. Should I get a second opinion? Go straight to donor eggs? So I think there's 2 big questions here.
Yeah. With respect to the thyroid, this is not the hill to die on. When you look at the guidelines about thyroid, you can pretty much make a case for anything you want, in terms of treating or not treating. And so what was that?
What do you do with the 3.53?
With a history of RPL, I'd probably give a little bit of levothyroxine. I would check for thyroid antibodies. If they've got positive antibodies, I would definitely give it. If it was someone who didn't have a history of recurrent pregnancy loss, I would probably not. But you can.
I would check antibodies, and if they're positive, then I would treat. But if they're negative, I generally don't. Yeah.
Like levothyroxine is a pretty safe medication, but there's risk to everything. And so if you don't have to be on something, don't be on it. And this is like, really, you can make a case for anything here. And so just doing it just to do it is not when everything else looks pretty good. And thyroid TSH varies a fair amount. You might check it in a month and it be completely within the less than 2.5 range.
So what about this question about donor eggs? What would you guys do?
So with having such a low AFC and even lower AMH and being able to get pregnant on her own, I think overall family planning is going to play a role. How many kids do you want? How tied are you to using your own genetics? And how frustrated are you? Like, are you ready to just be done and move on and get your family and go? Or are you still really married to the idea of trying to use your own eggs? Because like, you can make a case for using your own eggs because you've gotten pregnant on your own. It's just, it's a case where you have to understand this is going to take multiple cycles of IVF. There's no guarantee it's going to work, and you're in for the long haul. You can always cycle to donor eggs after that, but my kind of inclination with these numbers is to say, try once if you feel like you need it, because it sounds like they have not tried any
Yeah.
IVF type treatment.
IVF.
Yeah. So I would say, like, try once if you feel like you need to, but nobody's going to get in your way if you want to go straight to donor.
Abby, what do you think?
Yeah, I think if if your antral count's low and your AMH is low, I think the quickest route to pregnancy would be not with your own eggs, it would be with donor. But I think it just emotionally, you have to decide if that's something that you really want to do. Sometimes I'll have patients see my psychologist who does implication counseling. And I think it's really good sometimes for them not to feel, I think it's good for you not to feel pressured to do that. But I think talking to the person, at least in our case, who screens the donors, I think is sometimes helpful for patients. She also does implication counseling for our patients that are going to maybe think about using donor eggs. And I think it really just kind of helps patients sort of see things from different perspective. And it just helps them come to their own conclusion if that's something they really want to do or not.
I totally agree. Good stuff. All right. Well, today we are going to talk about different IVF protocols. So there is definitely an art to art assisted reproductive technologies. So, Carrie, what is one of the protocols that you tend to use?
So I would say my default protocol is to use to do the baseline on somebody, check labs, check ultrasound, make sure everything is quiet. If you've got a big cyst, if you've got hormone levels that are particularly high, in a way that's not acceptable to me, then we'll switch things up. But if everything looks good, I start you on FSH, so follicle stimulating hormone, which is a medication you give yourself. There are a couple different brands of FSH out there. Doesn't really matter to me which one you're using. My default's gonal, but I don't have a, I don't, not the hill that I'm going to die on. I don't really care. And so I do FSH, and then I usually start with Menopur as well. I'll do like 1 vial of Menopur, and then the amount of FSH is going to vary based on her weight, based on her age, based on her follicle count, her FSH numbers, like kind of the big picture. I typically give double dosing or higher dosing the first couple days because I want to get that level up quickly so that that cohort of eggs, that group of eggs that's available, all grows at about the same rate, same time, and they all get that initial push. And then I will drop the dose down a little bit later as I need to. And I tend to be a lab lover in the sense that we get blood all day, every day, and twice on Tuesdays because I want to know what your FSH is doing every day. Or not your FSH, your LH. I want to know what your E2 and progesterone are doing. I will also check FSHs periodically to make sure we're still in a good range. And so I'm totally a lab whore. And so we'll get all of that. And then, once the eggs are nice and big, and I don't go with the just 3/17, I want the bulk of them big. And then we trigger. I like dual triggers when I can get them. And again, we'll titrate the HCG trigger, which again, for the most part, I don't care what brand name is. I do tend to go to Pregnal Novarel HCG rather than like some of the others. But we'll
Terry,
do
what
the
do you
dual
mean by dual trigger? Explain that.
So dual trigger is with two ways to signal the eggs to be mature. One is with HCG. HCG is very similar to LH, which is the hormone your brain releases to get the eggs to get kicked out.
And when Carrie's saying very similar, it's structurally similar. So the body essentially recognizes it
Mhm.
as the same hormone.
Yeah.
Mhm. So so you can give HCG, which has the advantage of it sticks around a lot longer. It has the disadvantage of it sticks around a lot longer, so it's not
Mhm.
appropriate for everybody. And then there's also Lupron, which what Lupron does is it kicks your brain to dump out the bucket that is holding LH. And so as a result, you get that LH surge when you want it to. And so we'll
Provided you have a bucket in your brain of LH.
provided you have an available bucket, provided that you haven't done something previously that's going to empty that bucket already, which is other protocols we'll talk about. But that's typically the approach that we use. We'll do a retrieval 34 to 36 hours later, kind of depending.
Mhm.
Um, but that's kind of my standard MO.
So let's do this. I think that was kind of a good overview of some of the things that you can do, but let's kind of start off and kind of break this up and we'll compare different types of protocols as we go. Okay. So before you even start your stimulation, there's a couple of different ways that people will prep the ovaries or not prep the ovaries. What are some of those options?
I'm going to break in and ask a question for both of you guys.
Mhm.
When you have kind of a standard, like under the age of 35, hormone levels look good, nothing, no red flags. Let's say maybe it's male factor or PCOS or something like that. Do you always give pre-treatment or will you just let them start on their period?
Depends.
I almost always do pre-treatment. There's a couple of different reasons for that. One, I do like the idea you're talking about less than 35. We're not worried about ovarian reserve issues. And
Right.
I like to make sure that cohort is nice and tight. So, the
Mhm.
follicles are similar sizes. Um,
Hmm.
we also live in a world that more and more people, this sounds stupid, but more and more people are getting insurance coverage. All of these people who are going through IVF have to go through pre-authorization.
You
So
have to have time.
it takes 2-ish weeks to
Yeah.
get pre-authorization done. So I'm kind of like, well, if I'm having to take this time to do pre-authorization, I might as well take this time to get the nice tight cohort. So
Right.
usually not 100% of the time, there's always an exception to the rule. Again, the art to art. Um,
Hmm.
And you're
but
talking about birth control pills, right, Susan? Is what you're talking about? Yeah.
in this
Yeah.
situation, yes.
And I feel pretty much the same way. Almost everybody, if I have a young patient who has a good AMH, I really feel like it probably helps because I like to do the same thing. I say it's like baking cookies. You want the cookies to start at the same place and bake accordingly. You don't want some to be baked too quickly and too slowly. And I think that's what I think birth control pills do. They help kind of suppress hormones and kind of get the eggs all at the same level to kind of grow or bake at the same rate because it's just always disappointing if you have a young patient that has a bunch of eggs and one or two shoot way out and there's a bunch that are smaller and it's just hard to catch them up and bridge that gap. So I almost always start people on birth control pills. Sometimes in older patients, I'll pre-treat with estrogen, sort of with the same thing to try and synchronize those eggs so that they all start at the same place so that when we start to stimulate them, they all start to grow at the same rate and develop at the same rate.
So, Abby, you're talking a little bit about estrogen priming, which again, there's like a million ways to do estrogen priming.
Yeah.
But how do you do your estrogen priming?
We actually usually use estrace pills and usually start right after the trigger. And so then, or I'm sorry, right after ovulation, and then just have them use that for about 2 weeks leading up to when we start the FSH, when they start their period.
Carrie, what do you do for estrogen priming? Or do
I
you do
do
any estrogen priming?
I do pretty much the same thing. I will oftentimes pair it with Cetrotide or some other GnRH antagonist, whether it's Cetrotide, ganirelix, Amphastar, that set of meds, because I want to make sure that there's nothing that's growing up in between. It's rare these days that I do estrogen completely by itself. Um, I have found that my patients are more willing to take estrogen when I suggest birth control pills unless it's somebody who needs it for timing or there's additional factors that we're looking at, which is not really the patient population we're talking about at this instant. when I suggest birth control pills, I get the evil eye. Oh my God, they do not, they
Yeah,
are
but I think if you
not
explain it, I mean,
Yeah,
I know I agree with you. People like look at you like, what? Birth control pills? But I
yeah,
kind of trying to explain that we're just trying to sink the eggs, and at least
yeah,
that makes
there's a
some
purpose behind
sense.
it. It's not just preventing you from getting
Yes.
pregnant. It actually helps improve our outcomes.
Yes.
yeah.
Um, for my estrogen priming, I'm kind of similar to you guys. I usually start about a week after ovulation. And
Mhm.
so they prime for about a week-ish. And I usually use estrogen patches. And then I also use Cetrotide or GnRH. And then whenever they start their period is when we do that baseline. So once we hit that baseline, we start the gonadotropins. Those are the injectable medications that are actually stimulating your ovaries. In the United States, we, at this moment in time that we're recording, we have 3 that are on the market. So you have Gonal F, you have Follistim, you have Menopur. Can we discuss a little bit about the differences and what those 3 things are?
So Follistim and Gonal-f are both synthetic forms, or wait, I'm gonna say that wrong. Correct me, girls. Both synthetic forms
Yeah,
of
recombinant.
FSH.
That's the
Mhm.
way I would describe them. Yeah.
Yeah.
And so they are, and it's also called recombinant. And so it's just a mimic of what your brain is producing. And it's primarily FSH activity. When we're talking about gonadotropins, there are 2 gonadotropins. One is FSH and one is LH. They serve different purposes in the body, but there is overlap between the 2 of them. And so the gonal and the follistim, those are FSH versions, and that's a little different than Menopur.
Mhm. Mhm. How is Menopur different?
Menopur has both FSH and LH, and it's actually an older drug. There was one time in my career when that's all we had available before we had pure recombinant FSH, and so it can be used by itself. And actually, I just inherited a patient from somewhere else that's purely what they used. The advantage of that may be that it has a little bit of luteinizing hormone in it. And we think that luteinizing hormone may help a little bit with the maturity of the eggs. And specifically, maturity means we want to make sure that the egg has kicked out the final set of chromosomes to make way for the sperm. And so sometimes we'll see patients that will go through IVF cycles and they make tons of eggs and they look beautiful until we take them out. And then they either don't fertilize well, or even before that, they're immature and we can't use them. And so we all kind of feel like a little bit of luteinizing hormone in some form or another may be kind of helpful. Sometimes I don't start out with luteinizing or with Menopur on every patient, but I do with some. And if we don't use that, sometimes we'll use what you guys mentioned earlier. We'll use little bits of Avodril every other day and have patients take those to kind of help with the maturity of the egg. But basically, Menopur has FSH and LH in it, and it's still the same units of measurement. So we sort of think of we can dial the dosage and get different levels now of medicine, but as a general rule, we usually increase or decrease in increments of 75. And so 1 amp of Menopur is 75 international units. 1 amp, I guess, of FSH is 75 units as well. So it sort of counts as if we add that in to your previous regime, that also adds the fact that we're going up on the FSH as well.
So just for some technicalities, I'm pretty sure that in Menopur, it's LH activity, but it's actually driven by HCG. I'm pretty sure about that. Um,
Okay.
I think I may be wrong, but I'm pretty sure about that. I personally do split dosing on almost everybody, which means some FSH, some Menopur. Um, and then, I think what Carrie pointed out early on was, a lot of us would like to push your ovaries a little harder at the beginning, and it's easier to back off if we need to, especially now that we have different trigger options, because it's really that initial push out of the gate. Like when you start a horse race, that's when the front runners are. We want everybody to get going all at the same time, and we really want them to have the most energy, because there actually gets to a point in the stimulation where whatever we're doing really doesn't have a lot of impact. Now, one thing that we haven't talked a lot about is as these follicles are growing over, a 10 to 12 day stimulation, one thing that we don't want to happen is you to ovulate. So what are some of the options that we can use to prevent ovulation?
Probably a more common thing is an antagonist, which would either be known as GnRH or centrotide. Usually we start that, most people would start that probably on the day 6 of stimulation. If the estrogen levels around 400 or greater, if you have a follicle greater than about 14 millimeters, we generally would start that medicine, and it really kind of intercepts your luteinizing hormone signals. It prevents you from secreting luteinizing hormone that would trigger ovulation, because your body's not naturally used to having 10 or 12 eggs grow, and so your body naturally wants to kind of trigger that. And so typically you start that, and once you start it, you continue it all the way through. That's one of the newest ones.
Carrie, what's an older way of making this happen?
So to piggyback on Abby first, the other medication that we can use in the midst of it, which is more related to the older form, but is a newer medication, is you do an agonist protocol. And so with looking at these are long Lupron protocols is another way that you can kind of term them. But what it does is it takes the activating part of Lupron and puts it to best advantage. So Lupron, when you look online and you do research, which Dr. Google went to a crappy med school, just so y'all know, but when you look online and you see all of the comments about Lupron, in many cases, they're talking about Lupron as being used for endometriosis, where you give a really quite large dose with the intent of shutting down absolutely everything communication-wise between the brain and the ovaries, so that there's no feeding of estrogen, there's no feeding the endometriosis, and the whole thing shuts down. Well, what we figured out is that we can use Lupron in different doses to achieve different things. So when we're talking about an agonist protocol, what we're doing is we start the Lupron before you get into stim. And the reason we started before is because there's a little bit of a flare effect. Even when Lupron shuts everything down, it gives a shout before it shuts everything down. And that shout dumps out the bucket of FSH and LH in the brain. And so your ovaries can respond to that and grow eggs, which of course at the beginning of a cycle, we want everything on the same page. So we usually start that Lupron in advance. That allows enough time for the medications to even out, for your body to quiet down, so that there's no crosstalk between your brain signaling and your ovaries. So that way, once we give you the gonadotropins, that we're in control of everything. There's no ability for that LH bucket in your brain to dump out and prematurely ovulate before we are ready. So that's kind of a long Lupron cycle or an agonist cycle.
And that's also known as a microdose Lupron flare protocol too.
So I would actually use those. For me, a long Lupron and a microdose flare are two very different.
I thought you were talking about a microdose flare because you said it shoves out hormones. Okay, so I'll talk about a microdose flare then.
Yeah. So when I'm talking about it shoving out
You're
hormones,
talking about day 21 Lupron protocol.
Yes, yes. So it shoves out those hormones prematurely, so that when you do start the gonadotropins, everybody's on the same page and the brain is down-regulated and is quiet.
So another way to use Lupron, and this is a prefixed, it's a certain concentration. So like Carrie said, there's 3-month Lupron shots, there's 1-month Lupron shots, there's daily Lupron shots, and there's microdose Lupron flare shots, and they're all different.
There's a lot of Lupron out there.
There's a lot of Lupron for a lot of different reasons. So microdose Lupron flare is basically when you start it. So a lot of times these were protocols that we used for people that didn't respond well, and we still use those today. It's sort of my secondary protocol that I use, but basically you start microdose Lupron early in the cycle around day 3, and you ultimately overlap it with FSH. And so what it does initially, it takes advantage of that flare that Carrie was talking about, in that the first few days, instead of that being at the tail end of your last cycle, it's at the beginning of your cycle where you're going to actually stimulate. So what it kind of essentially does is it produces a whole bunch of your own endogenous FSH. And then on top of that, we give you a whole bunch more of FSH that we inject. And so therefore, your ovaries kind of get a 1-2 punch. And I've seen people that respond to that protocol that are not, haven't responded to other protocols. There's another poor responder protocol that I use that sometimes people respond to that one first. So sometimes it's one of those things, like Susan said, it's kind of the art of medicine. You don't really know, none of us have a crystal ball and know how you're going to respond, but that's certainly, I usually use that as my secondary protocol, but it certainly can be something that can be really helpful for certain patients.
Do either of you use medroxyprogesterone acetate or Provera to prevent ovulation? I know at our clinic we've started doing that for certain people, more likely donors, things like that.
When do you do that, Susan? I'm curious. I've heard about that and I've talked about that a little bit, but I've never done it myself. When do you do that?
So, kind of some of the nuances are we generally do it when we do FSH only protocols. And then, Carrie, when do you normally start your Provera?
So when we started, we usually start it right at baseline with them because we have not found it to be reliable. If you start it later on in the same way that you would do an antagonist, doesn't work.
Okay.
And so we'll do it from the very beginning. I tend to use it as a secondary boost. Like if I've had somebody who's ovulated on an antagonist, I will add in Provera throughout the entire cycle.
What
You know,
dose do you use?
of Provera,
Yeah.
usually like 10 a day,
Oh, okay. Just so you
sometimes
do
20 a day. It's not a high dose.
high dose. Oh,
Yeah.
okay.
And then the other thing that we will use is Orlissa, which is the oral form of shutting it down. So instead of having to use an injection, you use that. And we've actually found that to be really effective. So if I have someone who I'm worried about ovulating through, Orlissa is my default now, and I'll do the twice daily dosing because
Oh, wow.
I've
You
yet
do
to have somebody
200
ovulate.
twice daily or 150 twice daily?
200 twice daily.
Wow, that's cool. I haven't done
Yeah.
that before.
How expensive is that? Is that real expensive?
Yes.
It's pricey.
Yes, that is a pricey way to go. But because they're only getting
It's not as
relatively
pricey
few
as another
pills,
retrieval.
That's true.
it's
That's
not as
true.
expensive as another retrieval, and it is less expensive than the full, like when you're dosing for endo, where you have to have it all day, every day for months on end. Like
Yeah.
Yeah.
we're talking about a short,
Time period.
7-day time period. And
Yeah.
so find that works well. We used the Provera for a long time, and I forget why we cut back on it, but we hadn't seen quite the same results on that as we had with some of the other methods. So I still pull it out and use it when I need it though.
Okay.
So kind of hopping over to the trigger, we talked a little bit about there's a couple of different options for trigger. We have the Lupron trigger, you have the HCG trigger, you have a dual trigger. What are pros and cons to those different things? I can say that I almost always do a Lupron trigger unless there's a counter indication for it. But
Mhm.
also 40% of my patients live 3 hours away from me. So safety and me not having to worry about ovarian hyperstimulation syndrome or OHSS is a big thing. So when would you do those different types of things?
I tell you, we almost exclusively use Lupron triggers now, and it took a long time for us. Changing things in our field is hard because we don't have a lot of evidence-based medicine. You sort of look at what other people do, and so we were really hesitant because we had really good success with what we did before with Ovidrel triggers. And I do think that Ovidrel triggers help the maturity of the eggs. If it's a patient that I think I can trigger with Ovidrel, I prefer Ovidrel. But I tell you, having lived through the first 10 years or 15 years of my career when OHSS was a big, big concern for a lot of people. It is, in fact, my nurse and I just said something this week because we had a patient that came in that was concerned about it, and she didn't really have a significant case of it. But we're like, man, we're so glad that we don't have to do these paracentesis in the office or admit people to the hospital. So I tell you anymore, it's kind of funny. It's almost like PTSD. When I see somebody that I know I have to use an Ovidrel trigger on, it scares me because to your question, Ovidrel triggers, if somebody's going to get hyperstimulated, it doesn't mean they will get hyperstimulated if they have an Ovidrel trigger, but if you have a really high estrogen level, or if you have a lot of eggs, or a combination of both, you're at much higher risk if you get triggered with Ovidrel than if you get triggered with Lupron. Rarely, rarely, rarely does somebody get severely hyperstimulated with a Lupron trigger. I think the disadvantage, at least my feeling with the Lupron trigger, is it doesn't always work as good as an Ovidrel trigger. I don't think the eggs are quite as mature when they come out. They're a little bit harder to come out with a Lupron trigger. But I think when I look at the risk versus the benefit profile, I think it's much, much better to do Ovidrel triggers because I think by and large, the great majority of people do fine with those types of triggers. And it really dramatically decreases their risk of severe hyperstimulation, which would put them in the hospital or require an actual procedure in the office.
So I do a ton of dual triggers. And so agree with Abby in the sense of if I'm worried at all, it's Lupron only to minimize the hyperstim. But I do like doing dual triggers. Avodril is not my favorite, if for no other reason than it's really hard to titrate the dose. Because it used to be when we were giving HCG triggers, you gave 10,000 units or maybe 5,000 units if you were worried about hyperstimming.
Yeah.
And that's like, those are big doses and they work really well for maturity. But if you're worried about somebody getting hyperstim, but you're also worried about maturity for whatever reason, what we try and do is I try and walk the line between, okay, I am going to give you a fraction of the dose. It's all weight based plus number of follicles based. So I've got the algorithm that's on a sticky note next to my computer, so I always remember it. And what we try and do is we titrate the HCG levels. So when we draw your levels post trigger, I'm heading for a specific point. And I know if I hit above that point, I'll be safe. I know at what point it's not going to work and at what point it is going to work. And so we tend to titrate doses so that we can give dual triggers safely more often.
Very good. Very good. You also mentioned labs. I would venture to say that Carrie draws definitely more labs than I do.
Oh, 100%. I draw more labs than everybody else except my partners.
Yeah. And so in our clinic, really, we're going to, check, potentially we'll check a HCG level at the beginning of your cycle, especially if you haven't been on birth control pills or something like that. And then throughout your cycle, checking the estrogen levels. And depending on what type of protocol you're on, we'll know what to expect from your estrogen levels. Not everybody's going to have the same estrogen profile, especially, if you're on a protocol that maybe you're taking some oral medication like letrozole, you're not going to have nearly as high an estrogen level as you are somebody else. And usually that's intentional. And we often use that for people who have blood clotting disorders or have a history of breast cancer, different things like that. And sometimes even when you're a diminished ovarian reserve patient and we're needing just to add another layer of stimulation onto that. What other things, talking about stimulation, do you guys ever use growth hormone?
Occasionally.
Yeah, and actually, I do think intermittently I'll have good success with that. There's one other type of protocol that we forgot, or at least that I use for a poor responder protocol,
What
and
is
that's
Go for it.
Clomid. So sometimes
Yes.
when all else fails, sometimes what's old is new again. And so even before my time, people would start out a lot of times for patients that were poor responders, if they didn't respond to, an antagonist protocol, with a really high dose of medicine or didn't respond to microdose Lupron Flare, sometimes Clomid will work. And so, and you never know if it's going to work or not, but literally you start out with Clomid 100 and overlap with FSH. And sometimes there again, I think it may be the patient's own endogenous estrogen that sort of helps things grow and develop. And so it really is a pretty easy protocol. And sometimes almost miraculously, you'll see a patient that doesn't respond to anything else. And then you do that and you're like, how in the world did Clomid that's cost $50 actually do so well? So it's definitely worth a try for patients that have tried other things. And I mean, I'm not saying don't expect, to get 20 eggs on it or anything, but sometimes for patients who maybe couldn't make it to retrieval because they had a low egg count, sometimes with Clomid that will work if it's overlapped with FSH.
Yeah, I'll
Do you
do it.
guys know if you give Clomid every day throughout the protocol and don't do just the 5 days, it will also prevent ovulation. So you don't have to give an antagonist at the same time, which is really helpful because you don't want to give
Carrie,
an
how have I not
antagonist
done
at the same
that?
time when you're giving Clomid because it's going to shut everything down and prevent the Clomid from working.
Say that again. What's the last part?
So you want to try and avoid giving both Clomid and an antagonist when you're still depending on the action of the Clomid to work, because if you're giving both at the same time, they fight with each other.
Huh.
But if you just keep going on Clomid the entire protocol, vast majority of the time, they're not going to ovulate. And if they do, you're usually only talking about 1 or 2 eggs. So it's a very different impact than if somebody ovulates on a full protocol where they've spent $5,000 on meds.
While we're talking about that, let's talk a little bit about like what are actual signs of ovulation? When is ovulation? No, we don't want anybody to ovulate, obviously.
No, we
But
don't.
like is
Until we want them to ovulate, at which point we want you to ovulate.
Yeah.
right. So let's talk about signs of ovulation and what are implications of ovulation.
So when your LH levels start to creep up, that's when we start to get worried. When we all of a sudden see a drop in estrogen,
Significant drop,
a
particularly.
significant drop, like a drop of 10 or 20, whatever, nobody cares. But if you're starting to drop in the hundreds or thousands, that is a problem.
Like a roller coaster and the car's going down.
Uh-huh. And there's no track at the end.
Uh-uh.
The other thing is when you see all of a sudden the follicles disappear and you have this big beautiful cohort, and then you go to look the next day and everything is half the size. If you see a bunch of filled in follicles all of a sudden, if you see a ton of free fluid associated with it, that is a pretty good
What's
sign.
free?
If patient is complained of a lot of pain.
What's free,
Um,
Carrie?
Free fluid is when you look in the ultrasound, when you're looking on the ultrasound, and instead of seeing just that mass of shades of gray in there, and then the black little bladder, you see black that's surrounding the uterus. And what that is black is fluid. And you can tell that there's some free fluid in there. And when you ovulate, your follicles release that fluid as the egg's getting picked up. And so it's normal to see a little bit of fluid after ovulation. If you're, and it's okay to see some during the stim cycle, but you shouldn't be seeing very much. And when you all of a sudden go from nothing to a lot, usually ovulation is what's happening.
Yeah, and it always makes me nervous, right before you do an egg retrieval on somebody, and they're like, last night I started having this really bad pain in my abdomen. And, that's when most of the time that's benign. And, you're going to have pain because your ovaries are big and full. But if it's a significant change in discomfort, that's when I start to worry. And that's when I'm like, let's take a look with the ultrasound before we go back for the retrieval.
So let's talk a little for kind of to close things up. Sometimes we do coasting. What is coasting?
So coasting is when somebody is doing so amazingly well that we're worried about it. And so we want them to just keep surfing on the medications they have rather than continuing to give additional medications. It's going to drive things up and maybe have too much of a response, such that it's not helpful. I think most of us, for the most part, we don't coast completely now. It used to be really, like, I remember when I first started, everybody coasted all the time. Now I don't see it nearly as much. I do see drops in doses, but it's rare that I see someone who has completely cut out their dose entirely.
The only time I ever did coasting, I've never done coasting in IVF for IVF patients, but when we used to treat patients more commonly with pure FSH and do insemination, if we were trying to get an egg or two mature, sometimes we would coast patients in those situations. With IVF, I just think there's too much riding on the line to coast patients because, you may do fine a few times, but if you do it enough, it's going to come back to bite you and somebody's going to crash at some point. So I typically don't do any coasting with IVF anymore.
So I do occasionally coast people. I don't usually coast people more than a day. And when I'm doing it, I'm still giving them their antagonist to help prevent them from ovulating. And coasting is actually the one time that it is okay for your estrogen to drop. That's actually
Yep.
what we want to happen. And so what we're hoping is some of those small follicles that are not going to be contenders, but they're just producing hormones, that they kind of fall out of the wayside and the big ones keep doing what they're doing. So I think, in somebody who, it is a option when we have a very, very robust response. So what about men's stem protocols?
So these go in waves of popularity. When we were talking about Clomid, that's a min stim protocol, and it's using very minimal medications to stimulate the ovaries to get just a couple of follicles. And these are very standard, very common in women who have really decreased ovarian reserve, where it doesn't matter what you do. You could give them every single med all the time, every day, all day, and get the exact same response as giving them 2 dinky pills of Clomid a day. And so that's what those min stims are. Sometimes people will come in who are in general not really candidates for min stim, and they say, oh, I want a min stim protocol. And it's usually based on saving money. And counterintuitively, it actually doesn't help you a whole lot, because there's some min stim protocols and people do it differently, where they'll give just a tiny bit of the gonadotropins along with Clomid or letrozole or something like that, so that you're saving a lot on meds. But when you have the capacity to get a ton more eggs, usually that serves you way better than intentionally not getting as much as you can. And so min-stim protocols are pretty, pretty minimal as they sound, but they don't
Yeah.
always serve you.
And
You
I
never
think
know.
go
You never
ahead.
know what's going to happen in the lab. Okay. And it's one thing if you only have 3 or 4 follicles and you're only going to get 3 or 4 eggs. But if you have 20 follicles and you only get 2 or 3 or 4 eggs, there's a relatively reasonable possibility that you might not end up with any embryos that are viable. And,
Mhm.
and so, and lab costs, as much as medications cost, lab costs are high, and the more follicles you have, actually the less medicine you need. So it's one of those kind of a little bit counterintuitive things where you really have to find the balance in that.
Yeah, I tend to see mini stem protocols now are really more marketing techniques. They're ways to get people into
Mhm.
IVF. And, I think they do have a valid point. It's cheaper for medicines and things like that. But to Susan's point, if you're paying out of pocket for everything, the most expensive part of that is the egg retrieval. And if you only get 1 or 2 eggs, it's like buying lottery tickets for the lottery. If you only have 2 lottery tickets, you're much less likely to win the lottery than if you have 12 or 14 lottery tickets. And so really medicine cost is really a small portion of it, but you're going to pay the same for the egg retrieval. So in the long run, it's probably going to cost you more money rather than less money if you do a mini stem.
Absolutely. Good deal. Well, I think we covered a lot today. So that was a good talk.
That was a ton of information super quickly. Most of the time I tell people, oh yeah, listen to us on like 1.25 speed because you can get through more episodes. This one, go back and slow it down and take notes.
Well, and one thing I would point out too, and sort of intuitively, we've all implied this, but not every doctor does everything the same way. There, like Susan said, it's the art of medicine. So if your doctor doesn't do things exactly the way we said that we do them, it doesn't mean anybody's wrong. It just means there's different ways to do things, and we all have our own little things that we feel comfortable with.
Yeah, a lot of people worry, oh, I was on 250 and I should have been on 200, whatever. The difference of 50 units is not
Not
much.
a big deal.
Like it's not going to make or break anything. And so know that those variations are okay and your doctor has their preferences probably for a reason. Um, but they'll be able to describe it to you.
Very good. All right. To our audience, thank you so much for listening, and be sure to tune in next week for more. Also, be sure to subscribe and leave us a review on Apple Podcasts. Would love to hear from you. We are also on Instagram, Facebook, and YouTube. So follow us, subscribe, and stay updated on all things fertility.
You can also visit us on fertilitydocsuncensored.com to submit specific questions you have about infertility. All questions will be answered anonymously on our Ask the Doc segment, so don't hold back. We love episode ideas, so let us know what you're thinking and what you want to hear.
As always, this podcast is for entertainment and not meant as a substitute for advice from your doctor. Great to talk to you. See you guys.
Bye.
Bye.